So there's a number of new combinations in AML, and the field is really moving at a breakneck speed. And even in the big cancer centers where we're leading these trials, we often have to be very swift on our feet and change the trial designs as we see data emerging. And the era of the large multi-year phase threes has really become more and more restricted in the United States because of the pace of development. So I think one of the drugs that is really pushing these combinations and is kind of the, let's say, the backbone of many of these combinations is venetoclax. So as many already know, the combination of azacitidine or decitabine with venetoclax in the frontline elderly AML not fit for induction has shown blockbuster activity, response rates of 71, 72%, CR/CRi, median overall survival of 18 months, and 3-year survival of more than 40%. So not something we have never seen even close to in elderly AML, and this has led to the approval of that combination. But we think that there's actually much more to the story with venetoclax, and so now we are looking specifically at 3 major combinations with venetoclax, which are all early, but the preclinical and the emerging clinical data looks very exciting. So one of them is combining venetoclax with IDH inhibitors. So one of my colleagues, Dr. Courtney DiNardo, has worked extensively on IDH inhibitors. They've also worked closely with Stephen Chan and others who did a lot of the preclinical work looking at potential approaches to developing synergy between venetoclax and IDH inhibitors. And based on this, they have developed 2 studies. One is with the IDH2 inhibitor in combination with venetoclax, and the other is with the IDH1 inhibitor in combination with venetoclax. The study that's already enrolled a good number of patients is the one with the IDH1 inhibitor, ivosidenib, with venetoclax. This one will be presented at EHA, and we are seeing some very striking activity, high response rates in excess of 70% in relapsed AML with IDH mutation. So I think that'll be an important piece of data to look at EHA. We hope to start the IDH2 combination soon as well. This will be multi-center. And the goal is that if these therapies, the doublets, without using chemotherapy and potentially even without using hypomethylating agents, remain this effective, we could really start looking at an era where we will have oral targeted therapies in AML. We have an example of this, for example, with arsenic without chemotherapy in APL, and we think maybe this could happen with IDH venetoclax. And the other approach is, well, for frontline patients, maybe we will build an AZA venetoclax plus IDH inhibitor, and that arm is actually also opening. So a lot of people always ask me, which would you use, AZA venetoclax and AZA IDH? And we don't think that this is a competition between the two. We actually think that ideally these can be used. Of course, we have to find the right doses, the right schedule, interruptions, sequences, and that's what these trials are looking at. But eventually, I think if we can give them appropriately, we could really improve that 3-year survival from 35-40% of AZA-VEN to maybe 70-80%.